Hi, everybody. I'm Andrew Lowe, and I want to start by thanking Clara Booth and the other organizers of this workshop for putting it together and inviting me to participate via video. I apologize for not being there in person and hope to be able to meet all of you at some point in the near future. So I'm a financial economist by training and trade, so I should probably explain what I'm doing here. A number of years ago, friends and family of mine were dealing with various kinds of cancer. And through that process of trying to understand what they were going through and being helpful, I realized that finance actually plays a really big role in drug development and delivery. And so over the last 10 years or so, I've been spending more and more of my research time taking ideas in financial economics and applying them to healthcare to see whether or not we could reduce the cost of developing drugs and increase patient access, while at the same time allowing investors to get a good rate of return. So what I'm going to talk to you about today is a topic that I call buying cures or renting health, how financial engineering can actually make gene and cell therapies more affordable. So let me begin with the observation that biomedicine is at an inflection point, and all of you in the audience know this a lot better than I do because you're developing a lot of the therapies that are helping patients and their families. So diseases like Leber's congenital amaurosis, spinal muscular atrophy, acute lymphoblastic leukemia, and many other diseases are actually being cured thanks to the amazing advent of gene therapies. So in the case of LCA, Luxturna, Zolgensma, Kymriah, and Libmeldy are just a few examples of the gene therapies are available. And most recently, Upstaza was approved in the European Union for treating aromatic L-amino acid decarboxylase deficiency. So this is what I mean when I say that biomedicine is at an inflection point. And my colleagues at MIT, Phil Sharp, Susan Hockfield, and Tyler Jacks, they published a monograph in 2016 commenting on this called Convergence. Convergence of the life sciences, physical sciences, and engineering. And biomedical experts have a way of characterizing this convergence. They call it the omics revolution. Every one of these omics has experienced tremendous advances and breakthroughs over the last decade, with the exception of one, and that is economics. We need to come up with better business models for funding all of these great breakthroughs. And that's what I want to talk to you about today. The question I want to begin with is, can we really afford all of these amazing gene therapies? And now I'm not talking about price gouging. Price gouging is unacceptable in any industry. But the fact is that all of these incredibly life-saving developments are extremely expensive. Luxturna, $475,000 per eye list price. Zolgensma, $2.1 million per treatment, and so on. Now, from an economic point of view, these treatments are extremely cost-effective because they provide a lifetime of health. But the problem is that given how large the price tag is, it's very difficult to afford them because of that upfront payment, both for patients as well as for payors. And there are 203 gene therapies currently in late-stage clinical trials in the United States and more in Europe and Asia. So this is not a small problem. We're talking about a tremendous advance in human health, but at extreme cost. So what do we do about it? How do we go about financing life? And the answer is actually pretty simple. At least I thought it was a few years ago. One possible solution that I proposed back in 2016 with some of my co-authors is drug mortgages. The idea of having a lifetime of health is equivalent to buying a cure versus renting health one pill at a time. Much like when we decide whether to buy a home and receive a lifetime of housing services, or we decide to rent housing 1 month at a time by renting a flat. And so this idea of buying cures versus renting health tells us that instead of expecting individuals to pay upfront for a lifetime of health, why not spread out the payment over a period of time? Why not allow payers and patients to engage in drug mortgages? And so, it's clear that because the cure is a benefit for the entire lifetime, we ought to spread out those payments over a lifetime. And as a financial economist, we have very simple ways of doing it. Let's take the example of Zolgensma, $2.1 million. how do we spread out that payment over a period of time? Well, using a standard mortgage formula that I teach to my first-year MBA students, we can actually show that with a $2.1 million price tag, if we spread out those payments over, let's say, a 10-year period of monthly payments, then we're talking about, at a 5% rate of interest, a monthly payment of about $22,000. Now, $22,000 is not a small amount of money by any means, but for an insurance company or a payer like national healthcare systems, it's actually much more affordable than expecting to pay out $2.1 million upfront. In fact, if you look at $22,000 a month over the course of a year, that cost is not that much different from what we pay routinely for various kinds of cancer drugs. And so this is an idea that makes these kinds of therapeutics more accessible to a larger number of individuals and health plans. Now, is this a really good idea to start creating these loans? Well, there are many, many reasons why using these drug mortgages is in fact a good idea, and these are just a few of them. But there is one problem. And the really important challenge to this proposal is the fact that there is insurance switching across plans, at least in the United States. In multi-payer systems, the problem is that you might be in one health plan, and if you get the disease that requires a gene therapy at that time, that health plan might pay for it and then amortize the costs over a period of, let's say, 5 or 10 years. But if after 6 months you move to a different state, different location, and have a different health plan, then that original health plan is stuck with those payments, but you've now moved on, healthy that you are, and are making your premium payments to a different health plan. So that's not going to work. And so the idea of dealing with this issue requires that health plans are able to move the mortgage payments to follow the patient. In other words, if you move from a health plan that's paying your mortgage payments for a particular cure that you've been given, then when you move to a new health plan, ideally, the remaining mortgage payments should follow you to that new health plan so that the new health plan is going to be paying for you and getting the premiums for your lifetime of health. The problem is that we need a change in our healthcare laws, and that's not going to happen anytime soon. So if drug mortgages don't work, then what do we do? Well, I've been working on a different approach involving subscriptions, or the so-called Netflix model. The basic idea is pretty simple. Imagine you've got an employer with about 1,000 employees, and at that size, they're most likely self-insured, which means that they cover their own expenses rather than going to a large health insurance provider. If even one of these members ends up getting SMA, that's going to cost this plan $2.1 million, which is a real problem because the typical budget of a 1,000 person plan is about $6 million. So a third of their budget has been wiped out now by just one occurrence of SMA. So what this health plan will do is to get reinsurance, meaning they will find a provider that will be willing to cover the cost of this particular expensive therapy in exchange for monthly payments of a certain amount per member per month. And so if that patient arises, then this reinsurance company will write that $2.1 million check to the company. The company will then pay that to the particular provider for the treatment, and the patient will get the drug. Turns out that reinsurance is extremely expensive, in some cases costing 200 or 300% of the cost of the therapy, which seems crazy, but that's what the markup is here in the United States and in many other multi-payer systems. So the question is, who is the lowest cost provider for this kind of reinsurance? And the answer is pretty simple. The lowest cost provider is in fact the drug developer. In the case of SMA, it's Novartis. But instead of reinsuring with money, Novartis can reinsure with drug. So the idea is that this particular company will pay Novartis a certain amount per member per month in exchange for having Novartis provide the treatment anytime any of their patients is diagnosed with this particular disease. Now, there are a number of advantages for this feature. One advantage is that this particular health plan is now covered at lowest cost possible, because there is no other reinsurance company that can undercut Novartis in terms of the cost of this particular treatment. Second, Novartis benefits because this particular employer is now paying Novartis cash flows right away. As soon as the drug gets approved, this particular employer would be happy to provide Novartis with a certain amount per member per month to cover its risk, because it knows that it's covered, and Novartis is now getting cash flows right away, not just when the particular disease happens to be diagnosed. And moreover, the cash flows that they're getting are much smoother than the lumpy $2.1 million payments every time a disease is diagnosed. They're getting paid per member per month, not only from this company, but from all of the companies will benefit from this. And imagine now if all of these other gene therapy providers, including academia, including academic medical centers and nonprofit organizations, are part of this plan as well, and now create that Netflix company that basically provides one-stop shopping, so that as a health plan, you contract with Netflix, and what you get are access to all of its many different programs, just like we do now for Netflix. Now, in order for this Netflix model to work, we need three components. The first is you need Netflix. You need an independent third-party intermediary to be able to set up the monthly premiums, to figure out whether or not the monthly payments are 50 cents per member per month for Zolgensma, or maybe it's $1.50 per member per month. It depends on the actuarial incidence and the size of the patient pool and the cost of the therapy and so on. And I'm happy to say that I created this company with some collaborators called Quantile Health, and we are now set up to be able to provide those calculations, and have even signed up one particular employer to actually be participating. So we're in the process now of contacting various drug providers to see whether or not they'd like to be part of the platform. The second thing we need in the US, not as critical for single payer systems like you have in Europe, but in the US we have a multi-payer system, so you need to deal with the appropriate regulations to make sure that in our case, the CMS Medicaid best price rule is actually going to not interfere with retreating patients in case the gene therapy doesn't work. We're confident that that's going to work out. And finally, ideally, you'd like to have centers of excellence across the country to be able to administer these gene therapies, because number one, you want to make sure that they get implemented correctly, so that if it doesn't work, we know that it's not the fault of the delivery as opposed to the drug itself. And second, more importantly, we need to collect data on the durability of these gene therapies, the incidence of side effects and so on, because that's going to affect the premium calculations for that independent third party. So having these centers of excellence and being able to collect that data will allow those premiums to be computed more and more accurately over time. And I believe that these centers of excellence are already starting to pop up in the US, and certainly in this audience, you're all capable of creating these centers of excellence right now in Europe. Finally, I'll say that this particular model works for gene therapies, but there are additional challenges for N-of-1 therapies, like the example of Milacen in ASO treatments, and we're working on those plans as well. I believe that we can come up with subscription models that would even fund these kinds of extremely ultra-rare diseases. I'd like to conclude with some personal motivation for why I'm doing what I'm doing. And it has to do with this man, Professor Harvey Lodish, the faculty in the MIT Whitehead Institute. And when I first came across Harvey's story, I decided right then and there, I want to be Harvey Lodish, and you will too when I explain. In the 1980s, Harvey was approached by venture capitalists asking whether he and his fellow scientists would be willing to collaborate to create a therapy for a disease known as Gaucher syndrome, a single gene mutation that prevents your body from producing important housekeeping enzymes. And without those enzymes, fatty acids build up in various organs, and by the time you're a teenager, if you have the more serious variant of this disease, you're dead. And so Harvey and his colleagues worked over the course of several years, and in 1991, the very first enzyme replacement therapy, Ceridase, was approved by the FDA. And that drug and many of its improvements have saved tens of thousands of lives over the course of the last few decades. And you might have heard of Harvey's little startup. It's called Genzyme. And in 2014, it was acquired by Sanofi for about $20 billion. But that's not why I want to be Harvey Lodish, although it's not a bad reason. See, I want to be Harvey because of what happened in 2002. In that year, Harvey's daughter was pregnant with her second child, Harvey and his wife's second grandchild, a boy named Andrew. Great name, by the way. Well, Andrew was diagnosed in utero with Gaucher's syndrome. What are the chances? So I asked Harvey about this, and it was a rather emotional conversation. I asked him whether or not in the 1980s he knew that he was working on a drug that would one day save the life of his as yet unborn grandson. And he said, I had no idea. The 1980s was before we sequenced the human genome, so we didn't even know we had the genetic mutation for Gaucher's. I thought that if I could do some cool science and help some patients, that'd be great. This is why I want to be Harvey. Because in 2012, his grandson turned 10 and developed the full-blown symptoms of Gaucher's, but he's doing just fine, leading a perfectly normal life thanks to the drug that Grandpa helped to develop. Now, I don't have a PhD in molecular biology and an MD. I will never be able to develop drugs that will save my as yet unborn grandchildren. But I realize something. I realize that we can all be Harvey Lodish if we invest in the drugs that will save our as yet unborn grandchildren. Finance doesn't have to be a zero-sum game if we don't let it. We can actually do well by doing good if we do it at the right scale. Sorry, I teach MBA students, so I've got to have some sound effects. In any case, thank you very much for your time, and thank you for doing all that you do for patients and their families. And I'd be happy to follow up with anybody if you're interested in exploring these ideas, and look forward to meeting all of you in person someday. Bye-bye.